Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and heart failure, it doesn't mean your heart is stopped. It means it needs help to keep up. And thanks to some incredible advances in medicine that help now comes in the form of a lot of little devices that we're going to talk about on this show. And on this episode, I'm sitting down again with Dr. Luis Hernandez, who is a cardiologist at the Monument Health Heart and Vascular Institute and the medical director of the Advanced Heart Failure Program as well, to talk about heart failure devices. And it's interesting, when I was telling everybody what the podcast was going to be about today, I would say, yeah, we're going to talk about heart failure devices. And the joke for us was, well, why would I want a device that's going to make my heart fail, right? And I'm sure you get that same thing. But when people hear that word or those words together, it does sound scary. Can you help us understand kind of what that means first, Doctor? And we got great visuals too. So if you're listening to this on the podcast, I encourage you to go check the video version of this out, because we've got some wonderful things to look at here as we talk as well. But let's talk about understanding what heart failure actually means.
Perfect. So I think we talked before, right? And basically what I tell people is there's two types of heart failure. One where the heart is weaker, and it's basically not pumping enough to have the demands of oxygen to your body, right? And then we have another one where the heart is normal or just stiffer, it doesn't relax, and which makes the pressures in the heart higher, and then that's why people feel out of breath. But in reality, it's kind of similar in a way or another. So today, I decided to bring what do we have right now in the future heart failure, because heart failure has been growing so much, and I told you this before, right?
Right.
When I came originally, like 2 years ago, right? And now as a heart failure and transplant physician, there's so many new things that we have. Not all of this, I do it. I'm going to explain you who does this.
Right.
But what things we have in heart failure, what do we use in heart failure? Saying that, the most important thing is to follow with your doctor and take your medicine.
All the time. Now, even since the first time you talked a couple years ago, because you were the first guest on this podcast, has this changed dramatically for you in that 2 years in the devices and the things now that are happening?
Actually, not really.
Okay.
At least pacemakers, from the defibrillators and pacemakers, yes, there's new technology, but they were already there before. And some of these devices that I will talk today, they were already there before. We're just, now we know more, right? So we use them more often if you need them. And then what is new, which is not new, but new in the last, I'd probably say 3 to 5 years, is we do have monitors or pressure sensors that we can use in heart failure to really try to keep you out of the hospital. Saying that is very important that we talk about today. What qualifies for one of this, and when you should get one.
Right. Okay. So let's talk about this tech. And let's talk a little bit. Can you just kind of give me a general overview of what type of tech exists right now for heart failure?
Yeah. So let's talk about, obviously, as I told you, heart failure, there's a lot of different causes, right?
Yes.
I mean, name it, you have it probably. But what I'm talking about is when heart failure is caused by a valve problem or a structural problem, then we have the structural cardiologist. And one of them here is Dr. Tuma. Mm-hmm. So Dr. Tuma is our structural cardiologist. And what he does is, if your aortic valve, which is this valve that you see here, is not working well, so then we can actually replace it with what we call transcatheter aortic valve replacements. And there's two in the market. You can see here, these are the two we have here. That's why I brought this ones here. But you can see how this valve is being replaced by this valve.
And it looks like metal netting is what it looks like.
Yeah.
I guess that'd be a way to describe it.
That's a way to describe it, but it does have some tissue inside.
Right.
I thought I brought one small here. I guess I didn't, but there was a small one. Oh, let me see. I have it here. Oh, here.
There it is, yeah.
Yeah, so you can see it has a tissue is inside. So this is kind of like how they look in real life.
Right.
Really, this is like the size, right? A little bit bigger, obviously. But my point is, when the valve is the problem, that's the reason it's causing heart failure, so that we go ahead and replace, and we're talking about the aortic valve, right? This is the aortic valve. Then sometimes, which is not all the time, and now this is kind of like newer, but not new, because I was trained with it originally as a cardiologist. Then we talk about the aortic valve. Now we're going to talk about the mitral valve. So when the mitral valve is leaking a lot, sometimes, and again, these are procedures that can be done to your groin, meaning that you don't need an open heart surgery.
There's no, it just goes up through that.
Yeah, there's different accesses, but typically it's the groin.
Right, okay.
Yeah. So the good news is with this device is you don't have to get open heart surgery. Obviously, if you need open heart surgery, I always tell people that's the way to go. If that's the best way.
That's what you'll do.
That's what we do. Mm-hmm. And then the mitral clip, you can see this tiny clip. It looks like a clip here.
Yeah.
So the mitral clip, if you can see here, is a device that instead of having a big hole, if we can clip the middle, then you have two tiny holes. And then we can reduce the amount of leaky from that valve. And now we have this clip in the right side too. So, I mean, medicine has been growing so much.
And that's exactly what it is. It looks like just a little tiny, clip is the best way to describe it.
Yeah.
Because that's it's in one of the chambers of the heart.
Yeah.
It's kind of in that
the
lower,
valve.
in the valve
the
there.
mitral valve.
Okay, yeah. And
so this can be put only in the mitral valve or the tricuspid valve. Now, again, there's so much technology that there's a valve like this that you can put in the mitral, which I don't have one of those here.
Right.
And similar now in the tricuspid valve. So there's a lot, there is a lot.
Now, what type of heart condition would you have maybe generally in order to use one of those clips?
Yeah, so in this case, if your mitral valve is leaking a lot.
Okay, is there a name for it? Is there a specific term for?
No, it's mitral regurgitation.
Okay,
that's the name.
Got it.
But it has to be severe. And again, as I told you, and this is what I like for what I work, and that's the reason I work in Monument, it's about quality, right?
Yeah.
So being able to get a clip, if it's heart failure related, first step, Dr. Tuma will send it to us. We're going to try to get you in all those medicines because we always want to prevent you to get one of this. Mm-hmm. Our goal is if I can get you better with the medicine, that's the way to go. So if the medicine, you're already in the right medicine, you're still having symptoms of heart failure, we know this is the problem, the heart is not dilated yet or not that dilated, then we can go ahead and this. If the heart is already dilated and it's too far away, then the right thing is to do a transplant or a heart pump if you need it. But we want to do it before.
That can lead to, without that getting fixed, could lead to a heart pump or inevitably maybe a transplant as well.
If the heart is dilated.
I see.
Yep. Mm-hmm.
And we did do an episode with you on the heart pump. Mm-hmm. So if you would like to go back and listen to that through our podcast, you should for sure.
So my point is, I will only send to a mitral clip, and Dr. Tuma is our director and the one who does this. Mm-hmm. He knows that we put them in all this medicine. First, we optimize, we tune them up, we get them where there is. And believe it or not, there's medicines now. It is amazing. That's the way I can say it. To the point that I had patients who were sent originally to get one of this, and I was able to shrink, obviously not me, the medicines,
right.
To shrink that heart back to normal. Because the problem with heart failure and the mitral regurgitation is that the heart gets so distended that, do you see this tiny it looks like a parachute?
Yes.
Yeah, so it's being pulled. So when you pull them, it opens. So if we can reduce the heart size, then the parachute relax and then it can close normally.
I see.
So that was what medicines can do nowadays,
So do you think the medicines are moving quicker than the devices or vice versa?
I think.
Are they kind of just keeping pace with each other?
I think they go together,
sure.
Honestly speaking, right? But what I always tell people is if this is a mechanical problem, right? Because like a valve problem is a mechanical problem, mm-hmm. Sometimes you need to get a fix because if not, it's not going to get better, And that's where I help too. I tell them, this is what we're going to do. And I still have a timing, depending how things go, when we can actually do the valve or not.
Got it. Okay. Is there any of these? Did we miss any of these that you wanted to talk about? I know,
yes.
Or is this
right
here?
The structural
That's
and valve
the structural.
issues,
Okay,
right?
got it.
And these are the ones we have here. I always tell people we have everything we wanted here.
Yes.
Then in heart failure specifically, which is important after being in the medicine, right? And this is what guidelines recommend. As I told you before, when the heart is weak, less than 35%, so 3.5, guidelines recommend that most likely you will need a defibrillator. Mm-hmm. So that defibrillator is a recommendation because we know based on studies that patients who had low heart function or low EF less than 35%, and I say 35 because that's the cutoff.
Sure.
And again, depends on the cause, or either from blockages in the heart, or no blockages in the heart. If the heart function is less than 35, it's recommended based on guidance to get a defibrillator, okay? Saying that, what is a defibrillator?
Yeah.
People don't know what is a defibrillator. So this is a defibrillator. You see,
Right.
kind of fitting my hand, right? So it's a little bit bigger, as you can see.
Yes.
It's a thicker battery. That's why it looks a little bit thicker. Typically goes here. You see in this area here.
Kind of on the upper chest there, on the left
here,
side.
in the left
Yeah,
side.
Okay.
And this is what we use for primary prevention to prevent you to, if by any chance you have heart failure and then you have an arrhythmia, which is a normal rhythm, people typically will have a cardiac arrest.
Right.
So with this is like a policy that if this happens, it will shock you out and get you out of the problem. Saying that there's two types that we have, and this is another example, but this is not, the main one, but this is what we call a cardiac resynchronization therapy. As you can see, this has 3 small spots.
Yes.
So this is 3 leads. One goes to the right side of the heart, so basically here. One goes to the right side, and then the other one goes through this vein that you see here to the back of the heart. And with that, sometimes the heart, again, mechanical problems, the heart, instead of doing this is the way I explain to people, is doing this. They're not going synchronized.
So instead of your hands, doing it together, they go left, right, left, left, right.
So, and typically it's related to a left bundle branch block. So when people have a left bundle, which is a conduction problem, so we put the extra lead, and it will help the heart to kind of do this again.
Right.
That's the way to do it. And typically, this is just a pacemaker. That's why it's not thick. Typically, you want a big one. It will be like this, but with 3 leads.
Now, what you're holding, are they both considered pacemakers?
So all of them are pacemakers.
Okay.
The difference is, and I have a bunch of them. I can show you.
You did have, they come in. What's so amazing about it, I have never seen a pacemaker at all. I can't
So
believe.
you see how tiny it's different.
They are. Some are very small. Some are much, much larger.
And then you see this one. So the large one typically are the defibrillators ones because they need a thicker battery, right? And then so this one here that I was showing you, this is a pacemaker, defibrillator, and an extra lead. So this is the cardiac resynchronization therapy, right?
Now,
this is a sub-Q ICD. So
yes.
that's why it's bigger, because this one can go on the side, ideally in the left side. And this is for people who are like models and they don't want to be, they don't want to have the scar here. You see the one here.
Yes, okay.
Right? And this is just like an ICD. This is just the size of the defibrillator. You see?
Now,
so this is just thicker than the normal pacemakers.
Is having, this will be kind of a weird question, is having a smaller one better? The bigger they go, the worse your heart is, kind of a thing? No? Okay.
Well, I guess yes, if you want to say it that way. Because the bigger, you have the bigger one because you need more battery.
Right.
So typically it's only for the ICDs or defibrillators.
Okay.
Or the CRT, which is the cardiac resynchronization therapy.
Okay.
And we do both here, all of them. Actually, all the ones that I have there, they do it here in Monument.
Excellent.
And I say they do it because I don't do it. That is done by the electrophysiologist. And this is done by the structural people.
How many people are on those teams, doctor? Do you know right off the top of your head?
I don't know. I mean, I think the electrophysiologist, I think we have 3 plus, there's 3 nurse practitioners and, all of the people they have around, which I don't know how many.
Right.
And then the structural team for Dr. Tuma, he had, I think, 2 or 3 nurse practitioners, and then he had 2-3 nurses and Dr. Tuma. And that is in combined with surgery. That's an extra team that I don't know the amount. And my team, the heart failure team, is I'm the advanced heart failure physician. We have 2 other general cardiologists who does a lot of heart failure. And then we have 3 nurses just for the clinic, 3 nurse practitioners for clinic and hospital dedicated just for heart failure. And we have a nurse educator, coordinator in the hospital that will educate patients in the hospital. And I have one, what we call LPN, which is another kind of nurse that helps too in the clinic.
Okay. Now, the Heart and Vascular Institute, I know here at Monument has been an award-winning institution right now too. That's got to make you guys. I mean, you got to feel pretty good about that.
I always feel good about it. I always tell people. And actually, since you brought it up, because I forgot to share you this, I just got a message, I think like 2 weeks ago, where we appear in the Becker list. And I can open it to you so you can tell you the exact about we have the lowest readmission rate, top 5 in the country.
No kidding.
So it's a hospital review called Becker Hospital Review, and it's a list about a hospital with highest and lowest heart failure readmission rates. And if you can see here, we're number 5. on the lowest
look
rate.
at that. Again, it's got to make you guys feel like what you're doing and the work you're putting in just feels fantastic, right? To do that.
And that's what I tell people, at least for my area, it's about quality. And how many times I told you that, right? I was training Cleveland Clinic.
All the time.
Which I feel so proud about it. But Monument has everything that you guys need,
Right.
And I don't even see a reason why not to be here. We have everything, and it's about quality. We discuss cases every month. We have clinic. My nurses run with me at bedside. So I think the care, I can talk about the heart failure team, about my cardiology team. I think it's the best.
Now, you had one other device here that I wanted to definitely talk about, because this is, as somebody who really likes geeky, gadgety, techie things, how long is this? What is this first that you're holding in your hand right now?
So I'm going to show it to you here.
Yes.
I don't know if the camera will be able to see it, but you will see it in the
looks like a little
pictures.
transistor. It looks like
It looks like a butterfly.
Yeah, that's like a sensor in there with those two wires.
Yeah.
Okay.
So it's interesting you brought this up, right? Okay, so now as I'm a heart failure and transplant, right, cardiologist, so let's talk about more heart failure stuff.
Yes.
So I always tell people, the main thing that we would like to do for heart failure is to make sure you take your medicines, okay? I cannot emphasize the importance of how medicines in 2025 are. How I can tell you an example, a very nice example is the defibrillators, right? Mm-hmm. I told you about that heart number 35. I can tell you how much the amount of defibrillators implantation has dropped compared to years ago.
Just because of the medication?
Just because with the medicine, the heart goes back to normal.
Wow.
This is, I'm not saying we're not going to be off of transplant because their heart are sick, right? They're very sick heart. But the amount of defibrillator has been slowly trending down because GDMT works. GDMT, we call it to the medicine.
Okay.
It's guideline-directed medical therapy. So the medicine works. So I always tell people, please remember, the main thing is medicine. And it's not about, I'm taking this medicine for a year. Yes, this is a lifelong medicine. Second, all these studies, and again, gotta emphasize this more, were done in high doses. And that's one of the things I like from my clinic, right? So what we typically do, again, all this is quality, is we're trying to see the patient the first time we see. And then we have a heart failure pharmacist. I didn't mention her. She's amazing, by the way. And then we'll call you 2-3 weeks later after seeing us, because she will follow up to make sure that you have the medications, to make sure that you have all the medicines, and she will help me to go up in those medicines. And then we try to see you again in 1 or 2 months. Ideally, if we can see you sooner, we see you sooner. So that's why we use Holly, our pharmacist, in the middle, because the goal is to get you in all those 4 pillars. We call it the 4 pillars. Cannot emphasize that. 4 pillars. And we call them pillars because you need all of them. Okay?
Right.
It's not one is better than the other one. And please remember, all medicines, everything you do in life, right, can have side effects, right?
Of course.
So it is important that you tell your doctor, because I have a lot of people who says, I stopped this medicine because I felt worse, which is, I understand that, but talk to your doctor because there are other options.
Right.
So, and that's where I get concerned. I see all these people that had heart failure in the same medicines from 1970s, I guess. And I'm like, okay, how many cardiologists you had to see?
Right.
So my point is, please talk to your doctors about medicines to make your heart stronger.
Yeah.
Because we do have medicine. We want to prevent the heart transplant. Believe me, as a transplant cardiologist who doesn't want to see transplant, who doesn't want to do LVADs and transplant, right, and heart pumps. But our goal is really that you have a normal life, a good quality of life. But take your medicines, okay?
Right.
So that's the first step. For patients who get readmitted, and ideally multiple readmissions, then we have this, as we mentioned, this pressure, pulmonary pressure sensor. So what I typically do is I go through the neck or to the groin, go up in the lungs, and put this sensor in the lung. This sensor will stay in the lung. And we have another device. This is called CardioMEMS. I'm going to say the name because there's only one like this. And there's a new one coming called Cordella, which actually we're trying to see if we can bring it to Monument too. But with these devices, what they prove is that they can reduce readmissions to the hospital. Or basically, we know based on studies that the pressures, so the sensor will detect the pressures in your lungs. And when you get heart failure, when you're going to get an exacerbation or when you're going to get sicker, your pressures goes up. So this device is able to detect the changes in the pressure 30 days before you actually get sick. But what I tell people, it's not that we don't want to implant this in everyone. Yes, why not, right? But I always tell people, it's not about implanting this. It doesn't matter. If you don't take your medicines, this is not going to work.
Right.
Besides that, even this or the Cordella device, MEMS or Cordella, you have to monitor. This is like having a transplant. This is like having a baby. You have to sit down every day in a pillow, every day with a monitor. So you can check this every day so you can send it to us. So it's not just about putting it in. It's a doctor has to follow this through, right? Because you have to have someone, a team,
right,
that will follow these numbers going up, because you're not going to get a number. You don't get reported.
Right.
It comes to the person who put it in. Mm-hmm. So in Monument, what we did, just to make things better, what I ended up doing is I did a protocol, again, all this for quality purposes, where patients who get sent to us to get a CardioMEM device or a PA pressure device, they have to be seen by one of us first to see if they really need it. That's the first question. Does it really heart failure the problem? 2, after that, they have to have an hour session where they're going to be presented with the devices and with the pillow, because they have to lay down in a pillow, which I'm not kidding. It's triple the size.
Oh, wow. Okay.
So imagine you carry
so
a
it's a big,
luggage.
Right. All right. Okay.
Okay?
Yeah.
You have to carry a luggage when you go to the airport.
Okay.
Which is that device, right? And I had a patient, I always remember this. I had a patient who told me one day, Dr. Hernandez, I got that thing. And that lady always told me, go up, go down, go up, go down. Because the pillow will detect the sensor, and it has to be in a perfect spot so it can detect the pressures.
Right.
And that's probably where I think the new sensor will probably be better, because I haven't seen it myself, that it's this tiny, like a cell phone type that you just put in the top.
Oh,
so that will be a
sure.
thing, a game changer,
Yeah.
to be honest. But this is what we have right now, right? So my point is, you have to be in a pillow. So we show you that so you understand that. And then after that, even the day that you come and get it implant, we go through a list. We have a checklist of things of why not, which is why not, because we want to make sure, again, not everyone can get this. If patient need dialysis, they don't need this, because dialysis patient will have high pressures all the time. So it's basically useless, right? If you have pulmonary hypertension, you shouldn't get one of this. It's not the only indication for this is heart failure. And again, heart failure with multiple readmissions. And again, remember, this is like a baby. You have to be compliant. You have to take, measurements every day. And then after that, we brought it in, we implant the device, we give you another session education again, so you remember what to do. And again, we see you again in a week, so we can give you another session to make sure that you understand the importance. Because again, if I put it in and you never send a measurement, I'm just wasting your money.
You did, totally. And it's like you said, it's the follow-ups and everything you guys are doing with that is also the quality that you keep talking about.
Yeah.
I have a really silly question, doctor. Really
There's
quick.
No silly question for that.
Well, how does this lung pressure tie into detection of what's wrong with your heart?
Yeah. So remember the heart and the lungs, and I guess this is a good example,
Sure.
right? The heart and the lungs are connected.
Right.
I guess I don't have a good. I guess this one here. But
sure.
You see this? Well, imagine that the purple is the lung. Right?
Okay.
It looks like this to me looks like the PA. So this is the lung.
Okay.
So as you can see, the right side push the blood to the right side to the lungs. So the purple ones are the lungs.
Okay.
Okay?
Yes.
And then goes to the lungs, get the oxygen change, and come back to the left atrium. You see, to here.
Yes.
And this is the one that goes to the ventricle, out. The red one is the aorta.
Okay.
So when the heart is weaker, all the pressures here go back to the atrium, go back to the lung.
I see.
So what I do is I go in, put the device inside the lung, and then when the pressures in the lungs goes up, it's detected because all this is going back.
So, and up to 30 days.
Yep.
You can let you know 30 days in advance.
Yeah. So that's what I tell people when they tell me, oh no, it just happened in a day. It's impossible. Not impossible. Nothing is impossible.
Right.
There are some cases that is understandable, but most people should be able to detect this ahead of time, And that's one of the things I like from Monument. Like my clinic specifically, we have a special number just for our heart failure patients. And I always tell them, this is my speech. If you have nobody to talk, call us. If you want to talk to someone, call us. If you don't have anyone to talk, call us. If you think you know what you're doing, call us. Because most likely you don't know.
Right.
So my point is, This is preventable. Yes, I know there's some cases that it's not preventable, but I would say if we can prevent you to being in the hospital, it's not about not being in the hospital. It's about people understand everything that goes ahead being in the hospital. It means that you're sicker. 2, in hospitals, most likely you're not able to ambulate, but it will make older people especially, they will lose muscle mass so quick that after 5 days in the hospital, they can barely move. They need rehab. They need therapy. So I always tell people, home is always the way to go.
Yeah.
Because home, nobody monitors. You do your own thing. You do your own walking. You're not scared that you're going to fall from your bed. You do your normal things. You're in your normal environment, and that's always the way to go.
Now, I'm assuming a lot of people, one of the questions they'll ask with any of this stuff that you've talked about here, and again, I encourage you to watch the video version of this podcast as well so you can see kind of what the doctor was talking about. Can you live a pretty normal, active life as long as you're following the rules and taking the medication?
Yep.
And, it's...
Yeah, so this is my speech about, and I forgot I was going to bring you my book. We did a book that we actually give everyone in the hospital.
Oh, excellent, yeah.
That has all these things that we're talking about. But my speech in regarding activity and heart failure, I tell people the limit is you. And I said, this is what I want you to do. Let's say you want to walk a mile, right? So I said, let's say that when you're in the first block, you feel out of breath, you feel tired. Very simple. Stop. Wait until you regain your tiredness goes away, your breath is better, finish the mile. You see?
Yes.
So that means that if you have to stop 5 times, it is what it is.
Right.
But you need to start getting your body to work, because if not, believe me, the body love to not do anything.
Right.
And then exercise is good for the heart.
Exactly.
Especially in heart failure. So keeping that heart pumping, the medicines again today, I told one patient today, some of these medicines, there's studies that 18 days later, patients feel better. So I said, this is the way to go. I had a patient yesterday. I saw her in the hospital, and she's like, I have side effects to this. I have side effects to this. I have, and then this morning when I saw her, she's like, you make me think. That's what she said. Yeah, I'm going to take the medicine. And I was like, well, I told you, a little bit of everything is better than nothing.
Right, exactly.
And my point is, and that's how you slowly convince these people, because again, my goal is that they have a normal life. My goal is that they don't get a transplant. My goal is that they can have and grow up and see their grandkids,
Yes.
their family members, I think I told you, I have someone who's 19 years old. I think he's 20 by now. That, we have young people, and we want to prevent that. We want to make sure people have a normal life,
Right. Well, before, did we cover everything you wanted to talk about, Doctor? I don't want to miss anything on this one.
I think I covered the basic ones that I want to talk to them.
Very good. And for listeners who might be worried about themselves or even somebody in their life, what kind of signs do you look for? What kind of things shouldn't you ignore when it comes to your heart?
So, obviously, if you're having chest pain, you have to be concerned. This is in general, right?
Yes.
If you have a chest pain, think about if you have any heart blockages. But regarding heart failure specifically, signs and symptoms that I always tell people, if you get out of breath when you're walking, if you start gaining weight and it's only water weight, if you see your legs are getting swollen, if you feel that the swelling is going up, even your belly, that's not normal, okay? If you're not able to lay flat at night because you feel out of breath, if you feel, because I think I told you before about this, is when people have heart failure, the pressures in the lung, and sometimes they will develop fluid in the lung from all the pressure coming back. So when they lay flat, that pressure goes up and they wake up at night even gasping out of air. So those are the signs and symptoms I typically tell them. Obviously, there are a lot more, but those are the basic ones. So if people's feeling out of breath, that's number one. Swelling in the legs, people don't ignore it. That is important.
Get to your doctor, get to your primary care specifically, and start the conversation for sure. Dr. Luis Hernandez, cardiologist at the Monument Health Heart and Vascular Institute and the medical director of the Advanced Heart Failure Program. I love when you come in, Doctor. I love the fact that you are so passionate about this, and it completely comes across. And like I've said to other doctors on the podcast, if anything can make you feel good about a place that you live and the doctors and the professionals that you have. It's the genuine compassion and care that you guys bring to this. Yeah. And I think I can't stress that enough with you guys and who I've talked to. Yeah. So I'm so glad.
I think the quality. That's what I tell
the quality
people.
as well, all of it. I mean, from your training to the way things are handled through Monument, I think people should really, really just enjoy the fact that we have that here for sure.
I always tell people, you guys are fortunate.
Yes.
Because, and I told you this before, Cleveland Clinic, and I'm here, and I love this place.
Yes.
And you have everything that we want. Basically.
Well, I hope that whenever this podcast ends, I hope it never does, but you're going to be the last one on it, all right? Because we're going to bookend this thing together, okay, Doctor?
Okay.
All right.
I was the first one.
You were the first one. You're going to be the last one. Thank you very much, Doctor. I appreciate it.